Thank you very much for having us here and for giving us this grant award. My name is Nick Cohen. I'm a family doctor in Cleveland, Ohio.
And I'm Stephanie Canuck, and I'm a community health researcher also in Cleveland.
So I have three parts to this presentation. The first is where we could be with healthcare in the United States. And the second is where I think we are. And the third is how I think AmeriCorps can help us get from where we are to where we could be. So part one is where we could be. The following is an actual conversation between a healthcare provider and a patient, a new mom, who just delivered a premature infant in Cleveland, where I work, a city that has the highest infant mortality rate in the state and a state that has the third highest infant mortality rate in the country. And there's a racial disparity that makes this even worse. The chances of a black infant dying before their first birthday is over 4 times greater than the chance of a white infant. So the setting is a hospital room between a healthcare provider and the mother of a premature infant. I hope you'll enjoy this. It's the beauty of the healthcare provider's approach that I think shows us the way.
I went to jail last, can you hear me? I went to jail last summer and I got out and I was doing so well. Like I had 2 gym memberships because I like doing that. I like working on myself. And I was real confident and I felt real strong and I was sober. I never touched any drugs. Then I found out I was pregnant and I was like so upset because to me, pregnancy is not a good thing.
You saw it as a setback instead of a happy thing.
And everybody else around me was so excited, but yeah, as soon as I found out I was pregnant, I started getting depressed. I think a big part of it was because I used to have eating disorders. I thought like, oh my God, I'm going to get fat. This baby is going to ruin my body. I was angry.
The way you were able to identify that maybe the reason you were thinking of your pregnancy in a negative way was because of your past with eating disorders. You're really perceptive.
I think that was the number one reason why, because I was like angry, really angry. And it's usually like when I'm angry that when I want to do cocaine, not heroin anymore. I really don't have the desire to do heroin anymore. I learned to live without that.
You stopped using heroin. You don't do it anymore. That's amazing. If you just think about that for a moment, just pause. That's a huge step.
But cocaine is something that I want to do when I'm angry for some reason. Once I have it in my head, I'm doing it. That's it. I can't stop myself.
And you want that control back.
Yeah, I don't even know if I've ever had that control. I used to have compulsive eating problems before I even touched drugs. So I mean, this goes way back, and I've been through treatment. I guess maybe I haven't found the right one yet.
You don't think like that. You don't think they've been that effective.
I guess I haven't really had any reason to stop using. But I think having a kid is definitely a good reason to stop.
And if you were to imagine the future without drugs, what would that look like?
I would go back and finish college. I would save money up. I live with my parents still. I'm going to be 32 years old. I don't mind living there, but it's time to leave. I have a child now. I want to be able to take care of myself.
So in that short exchange, a cocaine-addicted new mom who had just delivered a premature infant went from being angry about her pregnancy and seeing the advantages of using cocaine to seeing her baby as a motivation to stop using and expressing confidence in her ability to quit and envisioning a future without drugs. How did that happen? Let's take a closer look. When the patient said, "I felt upset when I found that I was pregnant," the healthcare provider said, "You saw it as a setback rather than a happy thing." The healthcare provider was striving to see the world through the patient's eyes. Empathy. When the patient said she was worried the baby would ruin her body and that she used cocaine but not heroin during her pregnancy, the healthcare provider responded, you're so perceptive to see the link between your eating disorders and your feelings. And you quit heroin, that is such a big step. Affirming her strengths. When the patient said she had no control when she uses drugs, the healthcare provider said, you want that control back. Building importance. And when the patient said she couldn't seem to shake the cocaine habit, the healthcare provider pointed out that she was able to stop using heroin. That's a big step. The result of this empathic, strength-based approach, which is called motivational interviewing, well, the research is pretty clear that MI, motivational interviewing, helps people change across a wide range of health behaviors. But unfortunately, this healthcare provider's skill is the exception, not the rule. This is how things could be in healthcare, but usually are not. Now, to talk about the way things are, I'm a primary care doctor, and I was trained in the model that we traditionally use. It's a deficit model where we look for what's wrong with a person and prescribe treatment, and that works for something like pneumonia or a heart attack. But does my approach when I'm addressing behaviors work as well for acute illness, for cocaine addiction, tobacco use, diet, physical activity? Let's imagine what it would be like if I used that deficit model approach with that patient. I would say, cocaine is bad for your baby. Your baby is premature because of your cocaine use. You can't take care of your baby if you keep using drugs. What would you expect her reaction to be? Would it be the fantasized response, I didn't see anything wrong with my cocaine until you pointed it out to me. Thank you very much. Now I need to quit. More than likely, her response will be, you don't know what you're talking about, and you don't even know what I've been through. The traditional prevailing approach is notoriously ineffective at helping people change what matters most, personal behaviors. Only 1 in 10 people follow a healthcare provider's advice to change their lifestyle. And what's the cost of this ineffective approach? We're spending more on healthcare than any other country, and 80% of costs are due to personal behaviors. Personal behaviors are actually 4 times more influential on our lifespan than the healthcare we receive. So if we're here and we know what better looks like, why haven't we gotten there? The answer is we don't have the capacity to deliver something like motivational interviewing. There's a shortage of primary care providers, and by 2020, it's likely to reach 20,400. So part 3 is the surprise. That skillful healthcare provider in that story that we just had, she wasn't a doctor, she wasn't a counselor, she wasn't a registered nurse. She wasn't even a licensed healthcare provider, in fact. She was an AmeriCorps service member. She'd been trained in motivational interviewing to an objective standard of competence. That means she's good enough to deliver motivational interviewing in a clinical trial. And in August at University Hospital's Case Medical Center where I work, we brought on 10 AmeriCorps service members like her. In our first 2 months, they've coached over 600 people from the postpartum unit to the outpatient clinic, working with people on everything from drug use to quitting smoking, increasing physical activity, and improving their diet. With CNCS support, we're studying the cost effectiveness of this approach. And with positive results, other low-resource communities will be encouraged to replicate this program and to use this model when creating other programs. The tools we're building, including an online toolkit, will facilitate widespread program replication in other communities. AmeriCorps can bring healthcare in the U.S. from where we are to where we could be. Thanks.